Thank you, Professor Das. You know, my current topic given to me is that in modern type 2 diabetes management, we have a universe of choice. And what should be that universe of choice is what I'm supposed to speak on today. This pointer is not working here. Can anybody help me out with
Can
the
I have
pointer?
another pointer, please? Kumar, Professor Kumar.
It's not
Yes.
working here. No, no, this one? Okay. So this is my conflict and duality of interest, and this is an MSD symposium, we all know that. So what is this expert guide, or what is the universe of choice? So when you look at the word expert, Edward de Bono said that expert is someone who has succeeded in making decisions and judgments simpler through knowing what to pay attention and what to ignore. So it originated from Latin, expedi, then expertus, and then Middle English, transiting via French, called it expert. So it's basically derived from experience and hence mistakes. And it focuses on the process, yet simple and objective guidance towards the result. And it's driven by why, not how. So what is an expert's approach towards managing type 2 diabetes? Why? What is wrong in type 2 diabetes? How does that wrong manifest clinically? Why to treat type 2 diabetes? How is type 2 diabetes different in different individuals? And only then you can really come out with some guidance on how to treat type 2 diabetes and what are our options. So fundamentally, what I'm going to look at is the why, the how, and the what. So what are our options, and how should we really treat type 2 diabetes in modern era? So obviously the content of my talk is there has been a myriad of recommendations and guidelines in diabetes management. And that has been changing lanes all the time. Right from the secretagogue backbone, we have now just started moving into newer backbones. And therefore we have started from a step ladder pattern of diabetes management into a pathophysiological approach of type 2 diabetes management. And then obviously we have merits and demerits of the currently available treatment options. And therefore what next after metformin? What is the safety? What is the efficacy? And what are the composite endpoints is what I'm going to allude to. So in the good old days, the management of type 2 diabetes was symptomatic. Then came the pathology and then came the treatment. So if you look at originally the Egyptian, the Chinese, the Indian, the Syrian descriptions were all leading to the osmotic symptomatology. And then of course we had the elegant physiologist Claude Bernard in France saying that 1857 he discovered, and it's true today, that diabetes is due to excess glucose production in the liver. And then of course it was the Austrian scientists Minkowski and Mering who in 1889 said that pancreas has some role in pathogenesis of diabetes. And then of course physiologists Bayliss and Starling said that fundamentally to treat hyperglycemia you need a duodenal extract in 1902. But it was actually the pancreatic extract of Niccolò Polosov, who never got recognized and should have ideally got the Nobel Prize, okay, from Romania, who actually treated type 2 diabetes in the most elegant fashion. It was really not Banting and Best. So when you talk to students, what is wrong in type 2 diabetes? The usual answer is there is too much of glucose. And it is just not the only metabolic defect diabetes has. We now know that we have 3 core defects, and those 3 core defects have now moved to 8 core defects, and maybe we have 13 more defects coming up now. So there is a whole metabolic shift which is occurring from absorption of carbohydrates to glucose, fructose, galactose, which is all getting into the cells and peripheral tissues, and we have the liver bypass, looking at glycogen storage, looking at triglyceride stores and glycogen stores. So currently what we are recognizing are Defronzo's octet. We are looking at fundamentally the incretin effect, the islet alpha cell dysfunction, the beta cell dysfunction of insulin, the glucagon excess, the hepatic glucose production, the neurotransmitter dysfunction, the muscle glucose uptake and lipolysis in the fat tissues. And therefore if you look at the recommendation of the ADA ESD, they are looking at 7% A1C, less stringent in people who are getting hypoglycemia, longer disease duration, life expectancy is limited, a lot of comorbidities, a lot of vascular complications, people who are not willing to comply and have limited resources. So you can be okay at 7.5 if you are vulnerable to too much of hypoglycemia, have a long-standing disease, have a limited life expectancy, too many comorbidities or vascular complications, and you don't want to comply, and you are not so economically rich. However, you need tight 6.5 if you have no hypoglycemia, you are newly diagnosed in the first 10 years of your diagnosis, you have a long life expectancy, you don't have comorbid conditions or vascular complications, you are motivated, you are willing to follow, you are adherent, and you have a lot of resources available to us. And that is the current recommended approach from the two large societies from North of America and Europe. So obviously the treatment options are, the first step is the most critical step, often ignored, and it's not a medication step. It's diabetes education, increased physical activity, weight control, and healthy eating habits. And I exactly went on the reverse because that's the core of diabetes management. You need education, education, education. You need to be physically active. You need weight control. You need healthy eating. Then you have metformin. But after metformin, what next? Is it traditional 60 years old secretagogues? They're still alive. They're very much there. They're very potent. Is it the glitazones, which are still not out and they don't have safety issues anymore now? Is it the gliptins, which are virtually moved out? Secretagogues in the Western world as well as the glitazones in the Western world, and they have each themselves as the standard of care in the Western world and are very quickly replacing secretagogues and glitazones in probably even Asian countries. Then of course we have emerging therapies. Insulin has always been there in people who have catabolic cachexia. We have the GLP backbone, which is injectable, which is a very attractive option. And of course we have the latest kid of the block, which is the SGLT2 inhibitors. And obviously, that is where we are looking at. So step 1 is metformin. We all know it. 1 plus is what I'm going to talk about. Should it be insulin? It has hypoglycemia. It has very high efficacy. It has some hypoglycemic risk with weight gain. And the cost is variable. Should it be a GLP-1 agent? Well, GI side effects are existing. It is very good on efficacy. It has low risk of hypoglycemia, but it's high on cost. Should it be the traditional secretagogue? Well, hypoglycemia and weight gain still are there, but it's economical. Should it be glitazones? Well, they have issues of edema, water retention, heart failure, fractures. Forget the cancer issues. Of course, cancer issues have now been obviated, but again, low on cost in at least Indian countries. And then we have the big two. The traditional secretagogue has lost its place, at least in the United States and Europe, to a gliptin, and is threatened now by SGLT2. But really, is it a threat, or is it something which will be probably an add-on agent afterwards, is what I'm going to dilate today. And then of course, you can add and have 3 drugs coming up very quickly. So the summary of drug choices of the 2015 guideline is start with lifestyle and start with metformin, and unless contraindicated, and after 3 months if the A1C is not achieved, you can have one of the 6 options based on patient preferences, because there the patient has to be involved. It's a shared decision making, the disease duration and the drug characteristics, and the role is to reduce glucose without side effects, with no hypoglycemia, and preferably weight neutrality or weight loss. And obviously in special situations we don't look into this, and obviously dual therapy is emerging as a good option, and even triple therapy is coming up very fast. And A1C is about 7, 8, 9%, you can start dual therapy. Obviously you need insulin if there is osmotic symptoms, A1C about 10 or 12%, or a glucose about 300, 350, probably catabolic cachexia coming up, you need to start insulin. And obviously once the glucotoxicity resolves, the regimen can be simplified. That is how the current update is looking at. So from the efficacy standpoint, highest efficacy more than 2% insulin, 1 to 2% metformin, secretagogues, glitazone, GLP-1 backbone, and then 0.5 to 1% intermediate efficacy, gliptins and SGLT2. But in India, because we eat a lot of carbohydrates, the data shows very clearly that gliptins work. And of course, low on efficacy, we don't have too many drugs in that category. Maybe AGI has come in there. So we have two basic approaches. A guideline-based approach, which was the traditional approach of treat to failure. Add one agent, add second agent, add third agent. And then a pathophysiological approach looking at various defects. And let us look at an individualized approach and a simple approach. A, look at the age. Is the patient young? Is he elderly? B, body weight. Is the patient lean? Is he normal weight? Is he obese? C, complications. Are there presence of complications or absence of complications? D, disease duration less than 10 years, 10 to 20 years, more than 20 years. E, life expectancy or expectancy of life. Is there short life expectancy or long life expectancy? And of course, the next E, at least in India, is expenses. Because we are a resource limited country. And therefore, if you have this type of an approach, which is based on a algorithm, you probably will be able to give a rational approach to our treatment. Obviously, this also looks at the pathophysiological defects. The muscle and liver, glucose uptake and insulin resistance, the beta cell output of insulin deficiency, the alpha cell over excess of glucagon, the glucose diarrhea from the liver or the excess hepatic glucose output, the defects on the gut peptides or the GLP-1 secretory defects or GIP resistance, the lipolytic issues on the fat, the glucose reuptake by the kidneys, or a neurotransmitter defect of dopamine in the brain. So obviously, when we need to correct hypoglycemia, the basic question is, why do we need to correct it? Because we want to avoid complications, acute and chronic, and also look at recurrent infections, infestations for some forms of cancer. And we have a lot of challenges in treatment, and obviously tolerability of drugs, compliance may not look into all that. So let us look at each of the glucose lowering options. What does metformin does? It corrects insulin resistance mainly at the liver. It has no impact on insulin synthesis or secretion. It has no impact virtually on glucagon in a great way. It does reduce hepatic glucose output. It does correct glucosuria, but it has no impact on renal glucose reuptake. It corrects glucose. Gliptins don't have a great role on insulin resistance, but improve insulin synthesis, secretion, reduce glucagon secretion, reduce glucose output, correct glycosuria, again no impact on renal reuptake of glucose, and correct glucose. Secretagogues, no impact on resistance or synthesis, improve secretion, no impact on glucagon or hepatic glucose output, do correct glucosuria, no impact on renal glucose reuptake, correct glucose. Glitazones, correct insulin resistance. Synthesis, again, is a questionable issue. Secretion, no. Glucagon correction, again questionable. Hepatic glucose output, glucosuria correction is very much there. No impact on the kidney. GLP-1 backbone, except for insulin resistance, is very clean, except for renal glucose output. SGLT2, however, and I would like to reiterate, except for the renal glucose reuptake, really virtually has a clear no-no in every other part, whether it's insulin resistance, whether it's synthesis, whether it's secretion, whether it's glucagon, it's just not there. It's completely independent of all those mechanisms. It's a very different medication altogether, and it remains to be seen that in a humid environment like India, how will it stand the test of time? Because it has been successful in some parts of Europe and US, but whether it will stand the test of time of an Indian summer or a humid Indian coastal region remains to be seen. And of course, we have insulin, which is very much there. So the big fight is after metformin, is it SU versus gliptins? Are gliptins as effective as SUs? Do they reduce glucose quickly? Are they weight neutral? Are they safe with CVD? And are they safe in kidney disease? And look at sitagliptin versus SU, they are very similar efficacy. A1C reduction by 1.5% was observed both in SU and sitagliptin in this study in people above 9%. So at a high A1C, sitagliptin works as good as probably a secretagogue. And if you look at rapid reduction, within 72 hours you will see a sitagliptin working just like a secretagogue would work. So it's absolutely there. And on composite endpoints, okay, more than 3 times patients with sitagliptin group achieved A1C control without hypoglycemia, without increase in weight gain, when it was head-to-head compared with, say, glipizide. And the Odyssey study very clearly showed us that obviously it is more durable A sitagliptin metformin combination is much more durable than a secretagogue metformin combination and has a lower incidence of symptomatic, asymptomatic hypoglycemia. And obviously the glycemic durability of sitagliptin is also robust over almost 4 years. We know that secretagogues do not have that durability over time, but sitagliptin clearly has that durability over time. What about renal impairment? Well, obviously, head to head, again in renal impairment with a lower dose of sitagliptin, it absolutely compares well with any secretagogue and again tolerated well over 4 years. So we have now tolerability data. It's 7 years into the discovery of sitagliptin and it's very much there. And even in renal impairment, at a lower dose has lesser hypoglycemia, lesser weight gain and is very, very useful in renal impairment. What about risk of CV effects? We will have TCOS being released at Boston in ADA very soon. But the MACE analysis, meta-analysis reviews across board with more than 13 lakh patients clearly show that probably it has a reasonable hazard ratio to not make us alert on that. So probably it has a lower risk of CV disease compared to all other therapies. So obviously both reduce glucose very quickly. Both have similar efficacy, A1C to A1C. With gliptins, of course, the weight gain is less, hypoglycemia is less. SUs needs, of course, more dose titration adjustments. Gliptins are more durable than SUs in real life scenarios, and obviously in renal impairments there is better tolerability. And CV safety data with gliptin is building, data is encouraging. Of course, CV safety of secretagogues has been questioned in the past, but probably is neutral there. So after metformin, gliptin secretagogues was one issue. Let us look at the other thing which has suddenly come up now. The SGLT2 inhibitors, are they as efficacious as gliptins? Do they address metabolic abnormalities of diabetes? The answer there is clearly no, they don't. Are they useful in renal impairment? There are challenges there. What are the effects of enhanced glucoseuria? Because when you have too much of glucoseuria, what are the side effects of that? And what is the safety profile of SGLT2 because it's a new agent? So head to head, you can see here, Sita versus Cana, which is now available in India on a background therapy of metformin. Of A1C to A1C, you can see that the A1C to A1C, they are comparable. Okay, head to head, both the drugs you can see here are absolutely comparable and might have benefits beyond glycemic control, body weight loss because of caloric loss, maybe there, blood pressure reduction may be there, but remember in Japanese studies, sitagliptin has been shown to reduce blood pressure. But what about the metabolic abnormalities of type 2 diabetes? SGLT2 inhibitors have no effect on insulin synthesis or secretion at all. No effect on insulin resistance. Have been unfortunately shown to increase endogenous glucose production. That is, they cause excess hepatic glucose diarrhea, just like they cause the glucoseuria. And therefore, this increase in endogenous glucose production is approximately half of the excess glucose that is excreted. So they have a challenge there. And of course, they have been shown to increase glucagon production in alpha cells, which was a fact Dr. Binayak Sinha just alluded to. So they have a pharmacologically enhanced glycosuria, which results in a compensatory increase in endogenous glucose release and obviously lowering of glucose and insulin levels. So head to head, SGLT versus gliptins, I would feel gliptins are far better than SGLT2 in renal issues and renal impairment. What about safety concerns of SGLT2? They have safety concerns. They are not hassle-free drugs. They can cause polyuria, which can be very distressing for a patient. They will cause a lot of itching to the patient, particularly males and females. They have a huge side effect of hyponatremia and hyperkalemia, for which we need to be pharmacovigilant because we are going to use more and more of these drugs. They can cause hypotension in elderly, renal impaired, patients on diuretic, ACE inhibitors and ARBs. We know our patients with diabetes have ACE ARBs, they have diuretics, they are renally impaired and they could be elderly. You need to be careful of hypotension. Of course, the biggest side effects propagated is due to excess glucose in the urine, the genital mycotic infections. There's another peculiar side effect these drugs have. They increase actually the LDL cholesterol, just like rosiglitazone did. And therefore, they have some drug interactions with UGT inducers like Cana. And they are not recommended in severe liver disease. So what will you choose as an anti-diabetic after metformin? Okay, what are the options available? We need all oral options. They are reasonably effective, efficacy to efficacy. Different drug classes address different pathophysiological defects, but no single drug addresses all the effects. There is a considerable difference on safety profile of each class and individual molecules belonging to each one of them. which may affect patient selection. And therefore, it is practical to use safer drugs at an earlier stage, which will be effective and associated with better compliance. Okay, so what is the rationale for early gliptin use? Well, efficacy is similar, durability is there, combination therapy with metformin can be very synergistic. In metabolic management, it can be great. Safety with RCTs is almost comparable to placebos. CV safety needs to be looked at. We will have CV outcome trials soon. Renal impairment, they do well, and they have large experience with 7 years, more than 100 countries across the world. So what should be an expert's approach? Address the core defect of pathophysiology. Proven to address hyperglycemia. Ensure euglycemia, because remember, type 2 diabetes is a progressive disorder, and treating all the cores should not fall short after many years. An approach of reduction of blood glucose may be valid at that point, but most important thing is primum non nocere. First of all, do no harm. When you select patients, select them with minimal side effects. So obviously you start with lifestyle, so that patient stays active, ensure cells get their food, ensure beta cells do their job, ensure alpha cells react and do not overreact. Well, SGLT2 are a good option for core defects, but they don't address anything else. We need cautions in elderly people and elderly ladies, and we need a lot of evaluation. So when we are looking at, and this is my last slide, what do we need to do as an expert opinion? Treat the core defect in diabetes, in type 2 diabetes. Minimize complications. Maintain glycemic control. Add on or up titrate based on individualization and manage complications. Patient must be aware that lifestyle management has to be there. No drug works without lifestyle management. Also address blood pressure and lipids. And obviously if you do all these things, you would be able to get a choice after metformin. So I just gave you an overview. There was a little bias of a gliptin with after metformin because of its unique advantages based on 7 years of its experience. Thank you for a patient hearing.